Welcome everyone to Lecture 3 of our Pharmacology Explainer series. It's so great to have my first and second year pharmacy students here today. You know, you can hand a patient the absolute perfect pill, but if you don't understand how it actually gets out of their gut and into their bloodstream, you can't really help them. Mastering drug absorption is literally the bedrock of clinical practice, and today we're going to build that foundation together.
Okay, let's dive right into this. Here's our roadmap for today. We'll be looking at 1. The ADME big picture. 2. Navigating the GI tract. 3. Sites of drug absorption. 4. Mechanisms of drug transport. And finally, 5. Factors influencing drug absorption. Don't worry if this sounds like a lot. We're going to break this whole journey down systematically, step by step.
Let's start with Section 1, the ADME big picture, and the grand journey of a pill.
Imagine you just swallowed a simple paracetamol tablet. What happens next? Well, that drug's journey has 3 distinct phases. First is the pharmaceutical phase, where the tablet physically breaks apart and dissolves right in your stomach. Next up is the pharmacokinetic phase, which is all about how your body handles that drug. We use the mnemonic ADME here, or all drugs must exit. They get absorbed, distributed, metabolized, and finally excreted. Lastly, we hit the pharmacodynamic phase, where the drug reaches its target. And here's a vital clinical pearl for you. Somewhere along the specific journey, based on these exact phases, a drug will ultimately either heal your patient or harm them.
Let's focus in on pharmacokinetics. In plain English, this simply means what the body does to the drug. A great way to remember this is the mnemonic path of the capsule with a K, the exact path a capsule takes inside the body over time. Now, in clinical practice, this isn't just theory, right? If you have a patient with poor kidney function, you'll need to lower their antibiotic dose because their excretion phase is compromised. That is clinical pharmacokinetics in action. And a quick tip for your exams, always remember that pharmacokinetics specifically studies the time course of this ADME journey.
Now that we understand the ADME flow, let's move right along to Section 2, Navigating the GI Tract, where we'll look at the physical terrain of the gut.
To truly understand absorption, you absolutely have to know the terrain. Take a look at how these 3 regions differ. We can use a really simple memory trick here. Sour stomach, sweet spot small intestine, and slightly basic large intestine. The stomach is highly acidic and it has a smooth, relatively small surface area. The small intestine, our sweet spot, has a massive surface area because it's lined with these rough structures called villi and microvilli. And finally, the large intestine goes back to being smooth and small with a more basic pH. Your clinical pearl here. Those tiny villi in the small intestine are anatomically designed to create the maximum possible surface area for drug absorption. For instance, most of an oral dose of ibuprofen is absorbed right here in this sweet spot purely because of that massive surface area.
This perfectly illustrates the pH gradient of that terrain we just talked about. As a drug travels, its environment changes drastically. Just remember this. Mouth is mild, stomach is sour, then it gets sweeter all the way down. Your mouth is relatively neutral. Then the stomach drops to a highly acidic 1.5 to 2.0. From the duodenum through the colon, it steadily becomes more basic. Here's your exam tip. This gradient is exactly why acid-label antibiotics, like erythromycin, need an enteric coating. That coating protects them from the sour stomach so they can survive long enough to dissolve in the sweeter small intestine.
Now that we know the landscape, let's move on to Section 3, Sites of Drug Absorption, and pinpoint exactly where these drugs cross over.
So what actually is absorption, technically speaking? It's the movement of unchanged drug from the site of administration into the systemic blood circulation. A highly tested keyword here on your exams is unchanged. If a drug gets broken down before reaching the blood, that portion wasn't successfully absorbed. Think about taking oral insulin, for example. It gets destroyed in the gut before reaching the blood, so its absorption is effectively 0. To remember this definition, just use the mnemonic ASSC. Absorption equals site to systemic circulation.
First stop on the journey, the stomach. Because it lacks those rough villi, it has a pretty small surface area, which means very limited absorption actually happens here. Plus, its high acidity is just hostile. Acid-label drugs like penicillin G will be completely destroyed here if left unprotected. But the most important clinical variable about the stomach is the gastric emptying time. How fast the stomach empties dictates exactly how fast the drug reaches the real absorption hub.
And here is that hub, the small intestine. Think of this as the superhighway for absorption. Thanks to those villi we mentioned earlier, it boasts a massive 10 to 14 square feet of surface area along with a highly accommodating pH of 6 to 7. The The golden rule here is simple. The longer a drug stays in the superhighway, the more gets absorbed. And here's a vital clinical pearl for your future rotations. Transit time changes drastically based on food. Fasting transit is about 3 to 8 hours, but a fed state stretches that out to 8 to 12 hours. This is exactly why you counsel patients to take certain drugs like levothyroxine strictly on an empty stomach. Food fundamentally alters its absorption timeline.
Our final stop is the large intestine. Its main job is absorbing water, and it has a much smaller surface area of about 4 to 5 square feet. However, it plays a really crucial role as the catcher. It literally catches leftover drugs that escaped absorption earlier on. For example, some enteric-coated aspirins might not fully release until they reach the large intestine. As a quick exam fact, keep in mind its transit time is incredibly slow, sometimes taking up to 24 hours.
All right, let's look at Section 4, Mechanisms of Drug Transport. What's really fascinating here is we zoom in microscopically to see exactly how molecules physically cross those cellular borders. There are 5 primary microscopic mechanisms of absorption. Just remember the mnemonic PFAAP: passive diffusion, facilitated diffusion, active transport, aqueous pore transport, and pinocytosis. Let's start with passive diffusion. This is the route for most drugs, and it's completely effortless. It's exactly like spraying perfume in a corner of a room. The molecules naturally and effortlessly spread from an area of high concentration to an area of low concentration. This is exactly how highly lipid-soluble drugs, like diazepam, effortlessly cross over into the bloodstream.
Now we can actually calculate that perfume-like spread using Fick's law of diffusion. I know, the math looks a little intimidating, but let's demystify it together. Because the drug concentration in the gut is so much higher than in the plasma, the math simplifies to this. The higher the drug concentration in the gut, the faster it diffuses into the blood. Simple as that. Your P-exam tip here is the D in the formula, the diffusion coefficient. Think of it as a built-in speed rating that's specific to every single drug. For example, the D for a small alcohol molecule is much higher and much faster than it is for a large, bulky drug.
So a crucial point here is comparing passive diffusion to carrier-mediated transport. Remember our diazepam perfume? Well, it has no speed limit. The more you take, the more it spreads. But some drugs actually need a carrier protein to cross the cell membrane. Think of a carrier as a cab driver. A cab can only take so many passengers at once, right? Once all the cabs are full, the rate of transport just flattens out, no matter how much drug is waiting. The heavily tested keyword for this plateau phenomenon is saturation. Now, those cab driver carriers come in 2 forms. First, facilitated diffusion, which is moving downhill. It needs a carrier, but it flows with the gradient, so it requires 0 energy. My absolute favorite mnemonic here is B12 needs a buddy. Vitamin B12 relies on intrinsic factor as its buddy to cross the border. On the other hand, active transport moves drugs from low to high concentration. The memory trick? Active equals uphill plus ATP. It requires energy to push drugs like L-DOPA or iron uphill. And here's a major clinical warning. Because both mechanisms rely on a limited number of cabs, drugs competing for the exact same transporters will absolutely cause clinical interactions in your patients.
But what about electrical charges? Membrane charge deeply affects permeation speed. Use the mnemonic UAC for the speed order. Unionized is fastest, anions are next, and cations are the slowest. Cationic or positively charged drugs have a terrible time crossing because they face electrical gradients. But the body is clever. Permanently ionized drugs, like quaternary ammonium compounds, use a trick called ion pairing. They pair up with an oppositely charged natural substance, like mucin, to form a neutral complex. Just remember, opposites unite to cross the wall. Definitely flag this. It's a very tricky but super common exam question. Sometimes, the cell membrane just completely engulfs the drug. This is endocytosis, and there are 2 distinct types. Phagocytosis is cell-eating, used for large solid particles. Pinocytosis is cell drinking, used for liquid droplets. The mnemonic is super easy. Phago equals food, pino equals pint. A fantastic real-world example of pinocytosis in action is the oral polio vaccine, which gets absorbed this exact way.
Our final mechanism is pore transport. Think of this as a passageway for petite particles. Very small, low molecular weight drugs like urea or small sugars simply slip right through tiny aqueous pores in the membrane. Keep in mind, this isn't classic diffusion. The driving force pushing them through these passageways is actually hydrostatic or osmotic pressure.
All right, let's bring it all together in Section 5, Factors Influencing Drug Absorption. We're going to look at exactly what external and internal factors alter this whole process.
There are countless variables at play here, but we can cleanly group them using the PPF mnemonic: physiological, physicochemical, and formulation factors. Physiological factors depend on your patient's body, things like their gut pH, blood flow, and motility. Physicochemical factors depend on the drug's raw chemistry, like its particle size and solubility. And formulation factors depend entirely on the manufacturer's packaging. Is it a liquid, a regular tablet, or an enteric-coated capsule like we saw earlier with aspirin? Good absorption relies on all three of these working in perfect harmony.
Let's take a moment to recap what we've learned today. To truly master pharmacokinetics, you really have to appreciate the ADME journey. A drug doesn't just magically appear in the blood, right? It must first navigate the structural terrain of the GI tract, survive extreme shifts in pH from the sour stomach to the sweet small intestine, and physically cross cellular borders, whether by passively diffusing like perfume, catching a carrier cab, or uniting with opposites to sneak through. Understanding this absorption phase sets the absolute foundation for how the drug will be distributed, metabolized, and excreted, which is exactly what we'll tackle in our next lecture. I want to leave you with one final clinical thought to chew on before next time. If you have a patient taking a heavy dose of antacids and their stomach suddenly becomes basic rather than acidic, how exactly is that going to alter the absorption journey of an acid-labile drug? Think about the anatomical terrain and the microscopic transport rules we just covered today. Keep that in mind, and I will see you all in Lecture 4.